myself really quick. So I'm Courtney Strohaker. I am one of the pediatric cardiologists at Mott Children's Hospital and spend a lot of my time taking care of patients on the inpatient floor. Outside of that, I do camp every year for the cardiology week as their camp doctor. So North Star Reach Camp is near and dear to my heart, and I've been doing it since it started. So I'm going to be talking today about my talk, Heart Warriors, but essentially how I try and help families in terms of coping through education, where they can reach out for resources, all those sorts of things. And I see some familiar faces with children who I know are older. So I'll try and tailor some of what I'm talking about related to that, but also I think as this is a breakout session in a small group, hearing your input on what's helped you through this as well. So I'm going to save a lot of time at the end for just open discussion, feedback for me, for other things that I can do for the families that I take care of too, because I think that's super valuable. So I'm going to share some slides. They're very brief, just a few things that I put together. And then we'll go from there. So, here's that. All right, can you guys see it? Looks like Monica gave me a thumbs up. All right, so just a quick outline of how the main thing is when I thought about this and how I wanted to conceptualize this talk and what I wanted to talk about, I kept changing the outline, readjusting, because the topic is very big in terms of everybody's coming from a different place. You may have a baby, you may have an adult child, you may have somewhere in between, anywhere in between. And so your stage of coping and the kinds of things kids are coping with at each of these stages is very different. Two, how everyone copes is different. And so that I always feel like I'm tailoring what is best for the families I take care of based on what is the needs of that family. So that is another big portion of it for me, is figuring out what that is. And so as I kept going through this and going through the information I used for families, it felt very messy. And I'm sure that's how it feels for families a lot of the times too, is all the different things to make sure your kid is able to cope through all of the stages of being a child with congenital heart disease. It's not a clear roadmap many times. And so I kind of felt that messiness as I was trying to put this together. So bear with me on the organization, but I think it suits the topic. So first I'm going to talk about kind of just targeting for the parents. And so how to advocate and I think this is something that is relevant for children with parents of children with heart disease at all ages, how to advocate for understanding the illness at each portion of the time, how to find your network, and some plugs that I think maybe I uniquely will bring related to that. And then for the kids, and this is both for the children who have congenital heart disease as well as their siblings, and how that, and the whole family unit and how that goes. So first off, understanding the disease. So there's no magical resource for any one family or one magical resource for all families that helps for understanding, because everybody learns differently. So the kind of bullets that I wanted to just get out here is being able to express what you need, knowing what, if you do know, and I don't think everybody, including myself, always knows how best I learn, but trying to figure out how best you learn so that you can give that information to the person providing you information about your child's healthcare, so that they can then give it to you. So some families learn best with small tidbits of information at a time. Some want it all at one time. Some need learn best with pictures. Some learn best with everything put down in writing. And so I think families should feel very empowered to express how best they want to learn. As a provider, I want to be able to provide the information in the best possible way for the family. as we are going through the path. And that is something at diagnosis, right before surgery, years after surgery as we're just in maintenance phase, when new complications are coming up. Each of those times are a time that that I'm educating and trying to explain what's going on, and so knowing how everybody best learns. I want my families to know to not be afraid to ask questions. That's what we're there for. That's honestly why a lot of pediatric cardiologists got into this role, is that they like teaching, they like talking to families and teaching, and so this is a time that they get to do something that they really love. And then advocate for shared decision making. I think that is so extremely important, to make sure that your voice is heard, your child's voice is heard in terms of the plan, what's going to happen, how it's going to be done. Is the surgery going to fall close to a birthday and be important to move that over, or another special event in the family? If that's possible, if it's not an urgent procedure, being able to advocate for those things are all very important. And so I want families to feel empowered to be able to advocate for that shared decision making with their medical provider. All right, so then finding your network. So I think a lot of families are aware, or many, when I talk to families, are very aware of the networks that exist for family support. So if you aren't familiar with these, I'm going to touch on them briefly. But what I have found is that a lot of families are aware of these these individual groups. So Sisters by Heart is an organization that was built by moms who had children with hypoplastic left heart syndrome. So their focus is predominantly in that that domain, but can be a resource for beyond those that group of heart defects. And then they have a brother group for the dads of children with congenital heart disease called Bros by Heart. They have some very good resources regarding what they call Research Explained. They did this with a collaborative group called MPCQIC, I'll touch back with in a minute, that goes into the research that is out there and breaks it down in a way that is understandable for someone who hasn't had to go through medical school or nursing training or as a physician assistant. You know, it takes it down to the level that you don't need to have a high level degree for, and makes it understandable for families, which I think is wonderful. And I've used that resource many times with my families to explain where we're at on things. The great thing that Sisters by Heart has, and this is specific for hypoplastic left heart syndrome, but Conquering Congenital Heart Disease, their group also has this for multiple heart defects, is a guiding questions list for the care team. And again, I know this group has a lot of adult or older children with congenital heart disease. So though in those question banks are more related to at diagnosis, but do have some information on what to ask as things are changing. And Conquering Congenital, and then Mended Little Hearts actually has its adult component of Mended Hearts for adult disease. So they actually have a bunch of questions that go across both those domains, which is wonderful. So those are usually things people are already aware of, are those groups, but they do have, if you're not aware of them, they have regional, most all of those groups have like a regional chapter that will provide support groups to the families through all phases, again, of the journey with congenital heart disease, and do have groups for teenagers and adults with congenital heart disease as well. So it kind of has a support system through. I think that each of those groups are provide something a little different, and it's important. Something I always talk to families about in terms of finding these groups is these are all different groups. Some are going to feel more comfortable to you than others. So finding the place where you feel most nurtured and find your information the best is where you should go. There's no one perfect group for any one person. Then something that I think I have found families are a little bit less aware of is several of the learning collaboratives that we as cardiac centers are working together to improve the care for patients. So again, like I said at the beginning, every family is different in terms of how they cope, how they would like to work through this process. But some people are take action kind of people who want to be involved, and we are always looking for families in that. So if you're somebody who wants to get involved, all of these organizations have a parent guiding group. And this can be, it's not something we have to be on a big leadership role. They have parent advisory groups in the at the institution level as well, and where I think many of our institutions are looking for any parent to say, hey, you know, you're going to do this quality improvement project, but that doesn't make any sense to the families. And that's such a huge resource for us as we guide our work, is making sure it makes sense to the people who it's going to affect the most, which is the patients and the families. So I'm just going to touch on a few of them here, really, really briefly, so that if they are of interest to you, these could be a group you could reach out to at your own center on the national level. So NPCQIC, the little hearts, that little footprint of hearts, is the National Pediatric Cardiology Quality Improvement Collaborative, very verbose. They focus on the care of hypoplastic left heart syndrome patients, and they are now focusing on that care through the Fontan. So and have worked on multiple quality improvement projects in all phases of care to improve the lives of children with hypoplastic left heart syndrome. Underneath that is something called CNOC, is the Cardiac Neurodevelopmental Outcome Collaborative, which looks at neurodevelopment for children with congenital heart disease, and is doing lots of work there. They have a parent group nationally, as well as many centers have their own group at the center level that's working on individual quality improvement and research work. Over to the right, PAC3 and PC4, I'm going to put them together. They are, the PAC3 is for the cardiac acute care unit, or the floor, and PC4 is looking at ICU care for cardiac patients, but they also do a bunch of quality improvement work. Many, many centers have these organizations affiliated, and are always looking for parent involvement in terms of helping to steer quality improvement. And then at the bottom there is ACTION, and ACTION is kind of heart failure, transplant, and ventricular assist device type research and quality improvement collaborative across multiple centers, and again has a parent steering group and a parent advising group, both in centers individually as well as at the national level. All right, so those are what I wanted to say about that. And then the other thing I wanted to talk about today that I thought is another thing that when I talk to families and how I just sort of conceptualize getting ready to move along, is preparing for transitions of care. So this is at the patient level. This is my kind of patient and kids coping strategy that I work with. Is, for me, it's really important that my patients understand what their heart disease is. There's pretty good data out there that once congenital heart disease patients reach adulthood, that we lose many patients, and they don't get the care as frequently as they had, or are being advised to get it, because they're young adults and the world is coming at them from all angles. And so it is our responsibility as care providers to make sure that we're helping them get to the point of taking ownership of their own disease as much as they are able at each stage of their development. So what I do, and it's not, again, this is how I work it, and I think that there's different cardiologists that do it in different ways, and all are good ways, but I start even at the preschool age with my appointments, talking about things that I think are developmentally appropriate for them. Where is your heart? What is that on your chest? oh, that little line, do you know what that is? Oh, that's your scar. And then I tell them their story. I help them develop their story so that they can start telling it back to me. And it's pretty a simple story. My heart was unique and different for me, and that meant I had to have surgery, and now my heart is working better, but I still need to take really good care of it, is sort of how I talk to 3, 4, 5-year-olds about it. When we get to school age, kids are, and again, this is all school age, but really their developmental level is so important in this. So I do this based on gauging their developmental level. But I start to have them work on identifying medications, being able to tell me, do they take medications is usually where we start. And then by late school age, it's what kind of medications do you take and what are they for? And then understanding all the things that they can do. I don't like to focus on this is what you can't do, this is what you can't do, you're not able to do that if they have any kind of limitations or sports restrictions, but more of all of the things that they can do. I think that this helps them advocate for themselves at school when they're independent. And as this is a camp talk, especially at camp, having those kids at camp being able to identify their medications and understand what they can do and be able to choose what works for them. And then how to start talking to their peers about it. So I even ask them questions like, have you talked to your friends about your heart disease? Is that something you want to do? Do you need words to help explain it to your friends that you've had a heart surgery and things like that? Because some kids haven't ever broached that topic with their friends, but would like to. And then getting to teenage years, I actually tell all my teenagers, usually at about their 10-year-old appointment, I say, next time you come back, you're going to be telling me all of the things that you have. And so I stopped having them telling me about what the heart disease is, what their medications are, what they're responsible for. And then for teenage girls, we start talking a little bit about fertility and family planning, because not every heart lesion is particularly safe to go through a pregnancy. And so we start to talk about what that means and how we can go through that process together. If you aren't familiar, and then when I should say, the other thing we do is start to identify a time for transition. I start talking about a time for transition probably a little earlier than most people feel comfortable, but usually at their 11 to 12-year-old appointment. And so it's not that we're transitioning then, but I want them to start knowing that they're going to take ownership of their disease. And then eventually I'm not going to be their cardiologist anymore, and they're going to have an adult congenital cardiologist. And so identifying who that'll be, where they're going to be, and what makes sense for that. And usually making that transition, depending on the patient, sometime in the college, in the like 18 to 24 age group. Because the adult congenital doctors can serve them very well in terms of carrying things on. And I like to have a nice seamless transition so that we can make sure they're getting the care that they need. The ilovechange.org, if you're not familiar with it, and you is a transition tool online that Michigan works with, as well as many other centers, that allows patients to go in and start putting in their own information and get ready for that transition process, which is lovely. All right, so then these are all little kids, and like I said, I recognize a lot of faces of parents who have kids that much older than these books, but these are some great books that I think when I am talking to kids at the younger level about their heart or about going in for a procedure or things like that, that I use and have found beneficial for them to understand. I think it's important for them to see themselves in the world that's around them. I think that's what makes camp so wonderful, is they see themselves with other kids that have gone through some of the same things they have. And so these books also help with that, being able to see yourself in what you're reading. And I have a very long book list, longer than these books. So if you would like it, I can send that out on as well. And then preparing for surgery, I think is a big, obviously a very large part of the journey, and certainly preparing for surgery at different ages is different, and a big topic probably outside of the context for today, unless there's specific questions. But I think the biggest part is knowing the resources available to you and your child when coming up to surgery. So child life, we have many hospitals have child life in some way or another, doing that have all kinds of wonderful medical play type things that can begin in the clinic level and then move on into the hospitalization to understand lines, to understand the incision. There's a pre-surgical clinic to be able to see, tour the hospital, see, and this I think is important both for the parents as well as for the children, is being able to see where all of the things are, be able to picture this. And then social work is also a great resource for families in terms of being able to make sure you have all the resources necessary before coming in. But I think the biggest thing is being able to know, again, what is the best way you learn in these situations. And your child, and knowing and being able to tell your child's story to the teams that we can best make sure that they are comfortable and have the coping strategies that's necessary for them. And that's what I came up with. So I'm going to unshare, because really I wanted to spend a lot of time answering questions and getting input from, like I said, I noticed a lot of families who I know they have adult individuals with congenital heart disease. And so any input, any things that you think I myself can give to my colleagues to help with this transition is wonderful. Any questions?
This is Shelley Bowen. I'm trying to get my face up. Okay, thank you. So I think for us, my son went to camp years ago in 1998 in Florida, and he had cardiomyopathy, and so did my other son. And it's hard because there aren't always scars with cardiomyopathy, and you have a heart condition and you don't really know where you fit. And I think for parents as well, there's always outside, you always feel like you're kind of an outsider. So for me, I think everything you said is target on. I think, talking to the parents, doing transitioning in terms of feeling comfortable with talking about, the child, talking about their condition. But I think that's the one thing, that I always wonder, where do we fit when we have, with cardiomyopathy?
Yeah, absolutely. I completely agree. And especially because it's such a spectrum, there's, in terms of where you're at, and that spectrum changes over time for everybody. And in a family too, where you may have two individuals who are on different parts of that spectrum in terms of heart function and things like that. I agree with you. I've seen that at camp, that the kids who don't have a scar but have an ICD, or those sorts of things. So for anybody who doesn't know, an ICD is a defibrillator, or have a lot of dysfunction but haven't needed anything else beyond some medications, making sure that they all fit in. I think camp, it can still be very valuable, but it's definitely trying to find the way to make sure everybody's included. But then otherwise, from those standpoints, being able to give the child the voice for their friend, outside of camp world, for their friends to understand, this is something I have and this is something I'm going to have lifelong, and how to explain that developmentally to your peers when you're at that developmental level as well. So there's resources out there, but it gets difficult because this is such a messy area, because there's just, everybody's different. You have to find the right match for every patient.
I think even with the scars, sometimes there's a little bit of that, because your child doesn't walk around with their shirt up over their head all the time. So sometimes these kids look perfectly fine. You don't see their scars right away. And, so people think, well, what's wrong with that kid? He looks fine. And so there's a certain level of, when your child walks around with a feeding tube, they go, oh, your kid is sick. We get it now. But whether it's sports or being inclusive about other things at school or things like that, if the kids don't already know, sometimes that's the same thing, like you're saying, as far as fitting in and being a part of that. At camp, I feel like it's a little easier as far as the inclusiveness, but at your regular school or whatever, they are not inclusive at all. They're not nice a lot of times. And, you know, so like I said, sometimes even with the scars, you get some of that.
Absolutely.
But, and just to preface, my son is 15 going on 16 next week. And
happy birthday.
So, yeah. So, you know, just because you were talking a little bit about younger ones, and I know you recognize faces, we go to Children's Hospital in Detroit. So just to preface that he is a little bit older as well.
Yeah.
Yep.
Do they, have they introduced you to the iHeartChange website at all?
No, and Dylan is very lucky enough that we started out very first day one of him being at the hospital. He was just a day old, that we met his cardiologist, and his cardiologist actually sees adults. So he will not have to transition. But I do sometimes look at a website. It is the Wisconsin Heart. They have some things on there about transitioning, and like you're saying, starting much earlier, just talking about not so much transitioning to the different doctor, because that is one part of it, but also like you're saying, transitioning for the kids to kind of know. I'm surprised at how many older kids do not know what's going on and you know what happened. But I think years ago, many even before, you know, I'm talking, there just wasn't that much information. Parents didn't talk about it. They hid the scars. They, you know, I knew one lady who said she was told she was in a car accident. She had the very typical, you know, heart scar, and she didn't know until she was much older and married that she actually had a heart surgery. And that's amazing to me. But that's how it was years ago.
It's a teaching point I give to my medical students, and this is not just about the patient themselves, but the family as well. Is when we're rounding and we talk in sort of this vernacular, I talk to them about really gauging where the family is at in terms of their understanding, and not just say, you have a hole in your heart, you have a hole in your heart, you have a hole in your heart, but like, you have a hole in your heart. It's called a ventricular septal defect. And giving the families the language to continue on, or like, we're going to give you a medication. That medication is to help you pee more. It's called Lasix, so that they have the language to move on, because I think that's something that unfortunately the medical professionals don't always do a great job with, is making sure families aren't, I think there's two things. You either talk at a level that is, you know, they're so far away from medical training, they don't realize that they aren't, that this isn't all common knowledge, or keeping it at this level of like, I think you can only understand this, so I'm going to say this. And it's like, you got to give them the building blocks. It's a language that you're teaching families, and you've got to teach them just like you would teach any other language, like Spanish, or, you know, like, this is, you know, this is a this. So it's something I try to do with my medical students to get them to help families understand and be able to continue. I tell my families when I'm doing teaching, I'm like, we're doing this again today. Like, at every appointment, we go back through the heart and I draw it again. I'm like, this is what it is. Cause I'm like, I'm not expecting you to know all of this right away. It's a lot of information with a lot of
and I think sometimes it's so overwhelming in the beginning that you don't even hear all of it. You can't even comprehend all of it. So those building blocks are essential. And to hear it more than once, because maybe you've said those terminology words, but I got 4 of them, not 6 of them, or, you know, whatever
Right.
the case may be.
Absolutely.
Definitely. And I would say over this last summer, this last year, Dylan's he had to have surgery on his leg in July. Then they found out his pacemaker wire was broken. So they decided we do a CT scan that showed possible blood clots. So we had to do a heart cath. We did the heart cath, that was fine. Then they did a heart cath to try and repair the wire. or replace the wire that way in kind of a not ever been done before situation, but we were going to try it just to see if we could do it easier, and that did not work. So next week he will have heart surgery to replace that pacemaker wire. But all that to say, so many times we've been in and so many procedures, I said in this year, as he's becoming 16, I noticed all hospital staff speaking more directly to him than to me. And so again, speaking back to your transition, you know, cardiology is always, you know, just with the entire family and him and me and my husband and whatever. But I think all hospital staff, like looking at him differently and talking to him more directly and asking him questions more directly, you know, that I noticed it, you know, I mean, I knew it was coming, and you know, I'm just, as an observation, it's in that time frame that they really started talking to him. So that's kind of neat.
Yeah. Cool. Any other thoughts or questions?
I have a question. At what point it seems to me that, you know, as a parent, you grow up with a chronically ill child, or you grow up with your chronically ill child. Really, they raise you to be a different person than anything that was set before you, because most of us haven't, you know, that's not the book that we saw on the shelves of the joy of raising the chronically ill child, but it is a joy. But at any rate, the challenges are unique, and I think the trust issue is really difficult, and at what point you begin to talk to your child and say, this advanced therapy is going to come up, and saying it like 2 days before you're going into surgery is not the ideal time, because it doesn't build trust. I also think that advanced directives are important for anybody who's 16 years old and older, and I think it should be a family deal, just like game night, and everybody should sit at the table. Having lost a child, I can tell you, or 2 children, I can tell you that with my son, letting go of him was easier for me because we had that very difficult conversation. And I think, you know, we're all going to die. Every one of us are going to die. And I think it's really important to have those conversations. The question is, at what point do you begin or recommend beginning that conversation? It's hard. It's a real hard conversation, but in the end, you're thankful that you had it. At what point do you begin talking about that?
Thank you so much for sharing that, Shelley. And yeah, that is a big question, and a difficult one. I would say it's probably a difficult one for most providers, because I think what we do is, as a group, is wait until we think we're close to something like that, which is the absolutely wrong time to do it, right? So having that conversation when you're not going through the process of becoming near end of life is a little bit easier. It's not easy. It's never easy, but I think it makes it a little easier. I think that it depends on the developmental domain of the child, but I think high school years, as long as you think that they can understand it, is a really good time to do it. Once they start taking ownership of their own disease or understanding it, that should be the next phase of the conversation. So I think of it more of like a phased. When I do that, I do it in more of like, okay, we've gotten through these. I have sort of a set of steps I go through in clinic visits, like, okay, we've mastered medications. Okay, now we're talking about all the symptoms you should be watching for. Okay, now we're talking about the possible surgeries down the road. And then I go into that. And I'm pretty junior so far I'm a fetal doctor, so I have mostly 4 and under-year-olds right now, but I do have some teenagers that went in through surgeries, and we talked about it before they went. And a surgery that we expected to go very well, but you want to have those conversations well ahead of time. So thank you for sharing that. That's very helpful. Did I answer your question okay? too.
Yeah, I just think, we would expect, or we would hope that somebody with a healthy child would have that conversation, because the time to decide whether you're going to be a donor is not, is when Julie's running around, not after, not at bedside. And it seems to me, if we hold that same truth to those of us who have sick children, then it doesn't make it so scary. It doesn't become an avoidance issue. We don't want healthy people to have that, avoidance in the conversation. So yeah, it did help. Thank you.
Any other thoughts?
I think it's probably something that is avoided a lot of times. I think it could give the perception like, you're always in the frame of what are we doing next, to what procedure are we doing next to prolong life? What's the next thing? What's in it? So you have this sort of mindset of like moving forward to those things. And even though that's always a possibility from the very get-go, we kind of push it over there. So I'm glad you brought it up, because that is a really good point.
Yeah. Absolutely. And I agree. I think having the conversation when people are well, and with all people, like not just, I think if nothing this year, there are many things this year has probably shown a lot of us, but if nothing, it's shown us that things happen that we aren't predicting and can make people sick when they weren't sick. And so before, and if we're all already had those honest conversations, it's a little bit more preparation for everybody involved.
I agree. And to Deanna's point, I think that, I'm a co-founder of a support group. So I see this all the time, and there's this dread, but it's like nobody, so what happens is that when we model that dread, I believe that our children model that back, because they don't want us to worry and we don't want them to worry. And it's still there. I mean, they're still thinking about it. It's not something that they haven't thought about. But Deanna, to your point, I think there's this avoidance because we want to always be optimistic,
Right.
Absolutely, for our kids. And when you fought, you're fighting hard. It's all, for me, and I can't say for anybody else, but having that conversation for me, it was almost like I had to admit that this could happen. And the truth is, it's gonna happen, right? It's gonna happen. It just happened to your 96-year-old grandmother a few days ago. And it's just gonna happen. And there's no roadmap about when it's gonna happen. And making it more natural and having a conversation, I think is just, I feel like my son felt more betrayed because we talked about it 2 days before he was going into surgery. And, I'm glad I had it then because it came in handy later, but I just wish, my doctor would have been prodding me and saying, okay, everybody needs to decide this, everybody, and we need you to have this conversation now. And it wouldn't have been so dreadful, because I think that fear was like always there, and I don't want to give him permission to die. And it's weird, but it was there.
Was it like certain paperwork that you were going through, or a certain list of things that you wanted to cover with him, or how did?
Right. So it was his advance directive. So it was like, okay, what do we do if this happens? What do we do? Do you want to be tube fed? Which it's a conversation really, because you don't think about, being placed on antibiotics is an advance directive if you've got something going on. But to say, at what point do you let go? And what was really interesting with us was my son said, you have thought, he did not name me as being the person in charge. He did not name me as that person. And his reasoning is that he said, you have fought all my life to keep me alive. I don't know if I can trust you to let me go when the time comes.
Wow.
And and thank God he said that, because I was the person that was there. I was that person that had to let go, but I knew what his wishes were.
Right.
But it's back to Deanna's point. I mean, there was this trust that I don't know, and it was tearful. It was hard. But it was the most important conversation I ever had with my son. You know, I truly believe that I would be in agony to this day if I had not had that conversation with him.
Wow.
So,
Well, we've worked so hard from very early on with Dylan that, you know, the trust issue, like you say. So there's been times that we've been at the pediatrician that he had asked me before, do I get shots today? And I say, nope, no shots today. And they go, well, he is kind of due for that immunization. And I said, that'll be another day because I've already said no shots today. So we'll come back tomorrow. We'll come back next week. We'll come back whenever, but it's not going to be today because we, you know, so again, you know, we've done that work to a certain level and not to this level. But I think that factors in. Dylan has always been in the room for conversations. When they said it might be a heart transplant, when they said, you know, this or that's going on, he's always in the room. He's always part of the conversation. We had a friend, my husband's friend, who said, that's terrible that those doctors told him that he might need a heart transplant. And I said, what do you mean? That's his doctor. That's who's supposed to tell him. Like, I want them to be honest with him. He said, but that's your job as a parent to break that news to him. And I said, absolutely not. It's his doctor's job to tell him. It's my job as a parent to help him cope with that information and work through that information. It's not just my job to tell him. So, you know, we've always been very honest in that effort of trust. But again, just not to that level where you're speaking. So, yeah, that's very good info.
Mm-hmm. Yeah, it's a lot of relationships going on there, and
yeah,
you know, trusting your doctors and your parents, and it's an entire group effort, family ordeal, and
right.
Yeah, we've been fortunate that everyone's always been pretty transparent in our deal.
I'm sorry to interrupt, but this topic, my brother passed away last year, and it wasn't from anything related to his heart, but that was a conversation that my family had never had. Nobody talked about it because we were healthy kids and healthy parents. So as Shelley pointed out, just having that conversation as a whole, you know, it doesn't have to just be because you're going into the doctor. I wish that we had that conversation before. So as the other side of a family member who hadn't had it, it would have been helpful for us. So as another push for everyone to do it for themselves, but also to advocate to all of the families that you know of the importance of doing that, because you never know when you'll lose someone. So.
Thank you for sharing, Monica. I'm so sorry. That's really, really hard. And Shelley, I want to say, like, the way you said it was so perfect when you said it needs to be like game night. Like, it's just, we do this thing, we have Sunday dinner, or we have whatever. This is something that's happening. And the more you can just normalize the process, the better, I think. So thank you for sharing that, both of you.
And just thinking about it, you know, as it's brought up now, popping into my head is for people who have younger kids, you know, starting younger, it doesn't have to be about what do you want, what do you think, but just bringing up organ donation at their level, of course, but bringing up those certain things earlier on, but not directed to that child, but just in general, just that we've talked about it, or even talking with another individual about it, another family member, just so that it's in the conversation. And then as it gets older, you know, directing it to that particular child would, I assume, make it a little easier.
Absolutely. Any other thoughts?
I was just going to say something quick about transitions.
Yeah.
That's, you know, definitely a patient by patient basis, I know. And some of these kids who, you know, have gone through lifelong, and then they're going to leave home and have to, you know, deal with their own sort of medications and stuff like that is definitely difficult, because at some point you just have to equip them and, you know, trust that they're going to do what they're supposed to do. And then I also know that some struggle with the fact of, you know, they've grown up with this. This has been they're not defined by it, but there's, you know, everybody in their world, you know, birth through high school knows pretty much about their situation. And so when they leave, they might look forward to getting connected with a whole new group of people that have no idea that they even have a health condition. And so that is, you know, a little bit of a struggle for me just recently, trying to talk to my son about how, okay, that's fine if you want to have that sort of experience, but at the same time, then, you know, you still got to figure out a way to be responsible and to take your meds and stuff like that. And I mean, he does realize the importance of that, and I think he will do it, but there's that piece in them that wants to sort of experience what it might be like to get into a new world where they don't have to talk about that as being anything that's part of them, or no one knows that about them.
Yes, absolutely. And that's like a leap of faith for a parent, because it's like eventually you have to let them go, but it's incredibly stressful.
Yeah, that's hard. And then you think, how are they going to do this you know, get their meds and dispense their meds, and when they're, you know, going to different places and being able to have them on hand, you know, because you've sort of had a system in place for so long.
Yeah.
So that's a difficult thing to find an easy, you know, answer that applies to everybody in regards to transition. So yeah.
I know from previous talks and things, I've been always just wowed by the fact that there are kids who decide not to take their medication. Like they just want to rebel from it, and they don't want to be bothered. And I think, what? How, you know, we've struggled so hard. We've done this all your life to, you know, and then they go, no, I'm not taking them, or, you know, adolescents and young adults. And then, you know, like getting tattoos or whatever, and not having pre-med for that, or, you know, just different things like that. I relate it more to like diabetics who just, you know, when they've been diagnosed as very young, and they get to those teen years and they just go, I'm not dealing with this anymore. And of course they have to revisit it at some point, but yeah, that's always amazing to me. But I think, like we've said, communication is huge coming up to that.
Yeah, it's definitely not an issue that's unique to cardiac patients. I think that, like, I think the two areas I talk about the most is diabetics, and kidney transplant actually is another huge area. So, but see that we're coming to the end of our time. So thank you all so much for giving me the honor of talking to you all today, and for all of you sharing. It's been wonderful. If you want to reach out at all, please do let me know, and any other feedback of how I can help families better would be great too. So thank you.
Thank you.